the sadness in a world where tears are just a lullaby. If there's any answer, maybe love can end the madness. Maybe not, oh, but we can only try. You got to get up every morning with a smile on your face and show the world all the love in your heart. Then people gonna treat you better. You're gonna find, yes you will, that you're beautiful. You're beautiful. You're beautiful as you feel. Sitting here thinking, baby, about you. I'm wondering how I ever got through my life without you. Days passed me by, left my life somewhere behind. Games I was trying, left me old before my time. You came into my life almost like you knew the time was running out. I came running home to you. You taught me how to love you. You helped me to believe you could even love me. I was all you'd ever need. Sometimes when you're sleeping, I wonder if it's true. I'm afraid they'll come and take away this precious dream of you. But then you wake and hold me and love me through the night. Then I know that somehow everything will be alright. Thank you, baby, for giving me my life. I love you, honey, you've given me my life. Thank you, baby, for giving me my life.
Good morning. I see a lot of people are still logging in. So we're going to get started in a minute or two, if that's okay. Thank you for those who came early. I hope you appreciated the music. But we're just going to give it another minute or two before we get started. Again, for everyone who's just joining, we're just going to give it another minute as a number of people are still logging in. So we just want to make sure that they're logged on before we get started. But again, good morning to all. Okay, so good morning all. We will get started. For those of you who don't know me, my name is Mark Graham. I am the Vice President of Program Services at Coordinated Behavioral Care. And on behalf of CBC's team, I'd like to welcome you to our second installment of the 2020 Innovation Conference. As many of you know, our Innovation Conference was due to have taken place in March, but obviously because of COVID, we had to postpone that. And then ultimately we decided to run the conference over several mini virtual sessions. Our first session was held in October. The panel discussion was when a pandemic and an epidemic collide, and focused on the opiate treatment and how providers in that field had adapted during the COVID period. The monograph of that first session is going to be published shortly, and we will be sending that out via email to all of you here today. Ultimately, the purpose of the CBC Innovation Conference is to highlight the incredible creative work that has been done across the CBC IPA network. Had we met in March, there would have been an opportunity for attendees to view the 17 poster presentations that have been submitted by our network providers that showcased their innovative work and the positive impact their programs were having on the lives of New Yorkers. At each of our virtual mini sessions, we're taking some time to highlight some of these poster presentations. And today I'd like to share 3 of them with you. But just to note that at the end of the conference today, you will be directed to all 17 posters, to a link and a website that highlights all 17. And we hope that you'll take some time to review those posters. The first poster today that I'm going to highlight was submitted by Catholic Charities Neighborhood Services in collaboration with Genoa Healthcare, a leading pharmacy provider. Their poster detailed CCNS's experience with embedding a pharmacy in their Queens mental health clinic and the improvements in medication adherence and the reduction in hospital usage that were observed as a result of this partnership. The second poster is from Vibrant Emotional Health, submitted by John Orr and Minji Park. The poster focused on child and adolescent care coordination programs. Alex, would you be able to switch over to the second poster? Thank you. So again, this poster focused on Vibrant's Child and Adolescent Care Coordination Program. This service offers intensive emotional and practical support services to families and young people throughout the city. Finally, the Jewish Board's poster focused on their psychiatric nurse practitioner residency and telepsychiatry program, which aims to enhance access to care and retain quality nurse practitioner staff. The Jewish Board piloted the program at one of their clinics in February 2019, and within a year had expanded the program to 4 additional sites. Obviously, their work positioned them well for responding to COVID-19. And their poster makes a smooth transition to our topic of the day, telemental health. Our panel will be discussing the topic of telemental health, the silver lining of COVID-19. But before the panel, I have the pleasure of introducing our keynote speaker today, Brett Friedman. Since November 2019, Brett has served as the Director of Strategic Initiatives and Special Medicaid Counsel within the Office of Health Insurance Programs at the New York State Department of Health. In that role, Brett reports to and supports the Medicaid Director on key Medicaid initiatives that involve the complex intersection of legal, regulatory, and policy issues, and have the potential to shape the future of Medicaid programs in New York State. Prior to arriving at the Department of Health, Brett was a partner in the health care group of Ropes and Gray and co-head of the firm's digital health practice. In these capacities, Brett has developed significant experience in advising governmental and non-governmental clients on a variety of complex transactional, enforcement, and regulatory matters within the healthcare and digital health industries. Brett received a JD with high honors from George Washington Law School. He graduated Brandeis University, summa cum laude, Phi Beta Kappa. And so I'd like to thank you, Brett, for joining us today and sharing your thoughts and insights on telehealth in New York State. As Brett is doing this presentation, if you have any questions, please place them in the chat box. And at the end of his presentation, he's going to respond to those. And with that, I'm going to hand it over to you, Brett.
Great. Thank you, Mark. And thanks to George and others for inviting me to be the keynote today. I feel like being a keynote presenter is like being the best man at a wedding, and you have to give the best man speech and everyone's looking at you. But I'll try and not make a toast, but still provide some interesting information about the future of telehealth in New York State with a focus on telemental health and telepractice. And I'll discuss why New York State uses three terms for what's essentially the same thing, which always confused me being in the field prior to coming into state government. As Mark mentioned, I'm the Director of Strategic Initiatives. I'm also a counsel to the Medicaid program. I had the benefit of, prior to coming into state government, of being a digital health lawyer and advising both community-based providers and digital health companies on movement to telehealth. And telehealth has always been a promise and almost a silver bullet in healthcare. People kept saying, you know, with telehealth, with the advent of telehealth, we're going to solve rural access issues. We're going to decrease cost to the healthcare system. We can improve quality and provide innovative applications of technology to longstanding problems. But the problem was that telehealth and the uptake of telehealth was always limited. And I do want to provide some pre-pandemic and post-pandemic numbers to show you the experience we've had with telehealth in the last 9 months. I don't know, let me see if I can project my screen here. Oh, or Alex, can you project the slides? Great. Okay, yeah, one more, please. So this is the pre-pandemic Medicaid telehealth picture. As you can see, the uptick and the historical telehealth utilization, one slide back, please, has been incredibly small. But within the telehealth utilization, there were two shining spots. The first was behavioral health, and the second was E&M visits, evaluation and management visits, essentially, you know, physician office, just your basic physician office visits, depending on level of code of severity. All other forms of telehealth service were basically de minimis. Some of these numbers, which could you say, why, ED or nursing home, how could those be telehealth based? There were actually, a lot of this is derived from encounter data. And there was a lot of telehealth coding inaccuracy. But Medicaid, unlike most payers, offered telehealth parity, at least on a fee-for-service basis. So sometimes if a telehealth visit was occurring and the provider didn't code with a specific modifier, we didn't even know a telehealth claim was occurring. But big picture was that pre-pandemic, telehealth utilization was well less than 1% overall of the Medicaid program in claims and encounters. But as a distribution level by CPT code, behavioral health and E&M was always relatively strong. If you go to the next slide. Looking to the telehealth experience, Alex, if you could advance one slide, please. looking to immediately post-pandemic, so on that fateful day of March 13th, when the world seemed to shut down, there was an enormous explosion in the usage of telehealth for all manner of clinical encounter. We like to highlight the New York City H&H experience, which is a good cross-section of all services that a large public hospital system provides, especially one downstate in New York. Prior to the pandemic in February of 2020, they billed 500 telehealth visits. That includes E&M, behavioral health, other forms of telehealth encounters. In March, which was essentially a half month post New York State pause, they increased their 500 billable visits to 55,400, and then 83,000 in April, and it continued to grow. It leveled off in July, and it's probably dipped a little bit late summer and is spiking up again to sort of trend the data. But I like this slide because it shows the massive explosion immediately post-pandemic of telehealth utilization. The next slide, please. When we get there, it's a slide that shows this is data very recent from Fair Health. And for those of you who don't know Fair Health, it's a not-for-profit corporation established about 12 years ago that collects massive amounts of healthcare claims data and publishes reports to the public that helps inform all manner of healthcare decision-making and payment. They've been providing a monthly telehealth regional tracking report. It's free to the public. The website's below. I highly recommend checking it out because it's an enormously valuable telehealth data tool, among other data that Fair Health publishes. But they've done a Northeast regional comparison of 2019 and 2020. This data takes us and looks at September. And I really like this slide because it shows the importance of telehealth to behavioral health services. As shown by our own Medicaid data and looking at the top left-hand corner of this slide, behavioral health was always a heavy hitter in the telehealth realm. Even pre-pandemic in September 2019, a 45-minute psychotherapy session was the top billed telehealth code across the payment spectrum. This looks at payer data, not necessarily Medicaid fee-for-service claims data. And the rest of the services were your traditional E&M, physician outpatient office visit type services. But if you look to the September 2020 experience, the top two and three of the top five are now psychotherapy sessions. And that, we believe it to be a reflection of the fact that counseling psychotherapy services are a very good fit for telehealth and telephonic care delivery. And that was true pre-pandemic, and it's more true post-pandemic. And then on the right-hand side of the screen, you can see that, this is just the explosion of telehealth over the last year. The percentage change is over 7,200. And on the bottom, you can see that, again, behavioral health was a large driver of telehealth prior, but it's even more so now. And that's the experience also as we look into our Medicaid data warehouse and we look at our own fee-for-service data as we inform future policy decision-making. The next slide, please. What the next slide will show when we get there is that this is the OMH data that was published, and it reflects really the same message that as you look to the different OMH licensed services, Act, Article 31 Clinic, Mobile Crisis Pros, and the like, you've seen pretty much, you've gone from 0.35% total telehealth utilization, which was still, again, driving most of our telehealth numbers pre-pandemic, and you've been hovering around this 80 to 85% mark. We've seen dips over the summer when the rate of new infections was low. It's, although we don't have formally polished data yet, unsurprisingly, it's creeped back up into that 80% range, which, and we can close down the slides, which is just a reflection of the fact that telehealth has exploded. It's been sustained. And even as the pandemic has ebbed and flowed over the course of the last 9 months, the application of telehealth services to the telehealth to behavioral health or telemental health has been a sustainable and silver lining to the entire pandemic. And so even beginning as early as May, the policy discussions, or probably even April, the policy discussions started to say, how do we sustain telehealth long term? Enormous amounts of people have gotten online, have gotten comfortable, have been gotten used to the consent process. Providers have gotten better at it. Patients have gotten more comfortable with it. How do we sustain it into the future because of this promise of better access and lower cost? And we were immediately jumping into those discussions, and we tried to put, we actually tried to put the brakes on for a second, which is not the question shouldn't be how do we sustain telehealth? It should be how do we sustain telehealth in the right way? And can we use this enormous amounts of data to see if the promise of telehealth dating back 10, 15, 20 years has actually been delivered through the experience of the pandemic? Is it really shown to promote access? Is it saving cost? And if it's saving cost, is it saving costs in the right way? Is it saving costs because we're reimbursing providers less for the same service? Or are we saving costs because we're promoting adherence and thus reducing incidence of hospitalization, or reducing unnecessary transportation visits that we pay for on a fee-for-service basis? And so we need to look more into, where is the cost curve getting bent by virtue of telehealth services? Is the quality good? Are the quality measures that we use to measure adherence, to measure uptake, to measure performance, are those being met in the same way as fee-for-service care? And should we change the measures to measure the quality of services better? And then, do consumers like it? Is the patient experience good? Are people sort of gritting their teeth and saying, you know what, I can't go outside, I'll use telehealth? Or is this really, a great thing that they would prefer to do even when they, when the restrictions get released? And then how does the movement to telehealth fit into larger policy aims that have been coming out of the Medicaid program for years? Does it support and fit into our value-based payment ideology, into the roadmap? How does it promote health equity? Does it exacerbate health equity, or disparities in health equity, or does it improve them? So there was a conscientious effort of not wanting to drive the car as we were building it, but we were still very excited to be able to study the effects of telehealth and be able to make at least some short-term changes that were well received while we consider the longer-term picture, so we don't have a knee-jerk reaction to the expansion of telehealth in the wrong way. And so what we did was we worked to identify legal, reimbursement, and cultural barriers that have restricted the uptake of telehealth historically. The legal barriers, I would say, are who can provide telehealth? Where can they provide telehealth? How do people consent to receive telehealth? The reimbursement question is, what do we pay for it? And the big, the $25,000 question is, do we pay the same amounts for a telehealth encounter that we pay for an in-person encounter? Should we? Why or why not? And then the cultural barriers of, why do providers like it? Why don't they like it? Why do patients like it? Why don't they like it? Why do managed care plans like it or don't like it? And is it promoting the right type of care? Are you building that type of primary care, continuous care relationship, or is it sort of a one-off drop-in, get what you need and drop out care delivery model, which doesn't fit into, I think, our larger vision of promoting better healthcare for people on Medicaid? So we asked all those questions. We thought critically about them, and we've been then proceeding to develop a new policy platform. In doing that, I want to identify two different actors who have helped the Medicaid program in the course of this policy journey. The first, and you'll hear more of their name if you haven't already, is the Reimagine New York or Reimagine NY Commission. This was a commission appointed by the governor in late May, early June of 2020. It's being chaired by Eric Schmidt, the former CEO of Google, who now runs a foundation called Schmidt Ventures. And Eric Schmidt is chairing the Reimagine NY Commission, and they have a number of mandates to help make policy recommendations for New York to build back better. One of the work streams, and it's chaired by Dr. Toyin Ajayi from City Block Health, is looking at telehealth specifically. And there's a number of commissioners who are on the telehealth panel, Martha Pollack, the president of Cornell, and others. And so we have really smart people at the highest levels of industry thinking through the policy questions and helping the state make recommendations to improve telehealth. We in the Medicaid program, along with the governor's office, OMH, OASIS, others are working closely with the commission, which is staffed by Schmidt Futures, to make these recommendations. The other actor, as this group is probably aware, was the Medicaid Redesign Team 2 process. One of the Medicaid Redesign Team recommendations, which factored into the implementation plan that I oversee, is a comprehensive telehealth reform. And a lot of that was pre-pandemic work, but there were good policy ideas that we were trying to use to increase the application of telehealth pre-pandemic, which also worked post-pandemic. And we've had to reconcile what we were doing pre-pandemic to make sure it's still true post-pandemic, but we've done that as well. And so with the MRT2 recommendations, with the help of the Reimagine NY Commission, DOH, OMH, OASIS, OPWDD, and the Department of Financial Services, DFS, which regulates commercial insurance, have convened an interagency coordination panel or committee, and we've been sharing our policy ideas and aligning on them in hopes that in the coming weeks, as the governor finishes polishing his State of the State speech, which usually comes out in early January, there's going to be a comprehensive telehealth policy proposal that we can build on through the budget enactment process and into fiscal year 2022. So, you know, there's a lot of momentum, there's a lot of experience, and there's a lot of help coming out of the pandemic that you know will hopefully improve telehealth as a policy matter for years to come. And so I wanted to use the balance of my time, the last 5 minutes or so, to talk through some of the early thinking as to what's going to come out on a policy perspective. These are preliminary ideas. These are a lot of my own thinking, so don't take this as gospel from the government as to what is going to happen. But I wanted to give folks at least an idea of the issues and the policy questions being discussed that you may see when these policy decisions get finalized into the next year. Very quickly, there's going to be a number of short-term or quick wins that we will work to be implementing. The first is more provider training, what people have often affectionately referred to as website manner. Train providers how to get more comfortable and utilize telehealth through a training platform that's supported by New York State. Looking at ways to promote in-home facilitation through community health workers that can help individuals access telehealth technology if they lack the hardware or they lack the cultural awareness and uptake in order to do it appropriately. And to be able to pay community health workers to facilitate those telehealth encounters. The better publicizing of existing OMH resources that exist today and that tie into telehealth. things like the crisis text hotline or coping circles. And then there are longer term policy recommendations, some of which we have to take direction and guidance from the federal government, which is also examining its positions on telehealth reform. But the first and the biggest, and the one we're likely to get from most behavioral health providers, is long-term sustainability of telephonic-only care delivery. The big issue with telehealth as a long-term delivery is that the federal government doesn't treat it as a Medicaid-covered expense. So if you bill outside the pandemic, so it's a special exception, which is why we're able to do telephonic now. But once the public health emergency expires, we go back to the pre-pandemic status quo, and the federal government says we can't bill Medicaid claims and get our 50% on it if it's telephone only. It needs to be real-time audiovisual or synchronous or one of the other permitted asynchronous modalities. And so that's going to be a big limitation. And so we've been working with the federal government to think about ways to cover telephonic, especially in the areas where it's shown most promise. And I would say where it's shown most promise is those type of psychotherapy and behavioral health encounters that have utilized telehealth most effectively during the pandemic. Other issues being considered are the ability to expand interstate licensure. Right now, if you're a doctor and you are in New Jersey, for example, and you are not licensed in New York, you cannot see via telehealth a patient in New York because you're not licensed in the state in which the patient is receiving the telehealth encounter. And so we're looking for ways to promote interstate licensure reciprocity for telehealth delivery, especially in areas like behavioral health where there have been historical provider access issues. From the earliest days that I've been a healthcare lawyer going back 13, 14 years, I know you can't find psychiatrists in South Brooklyn. And so to be able to, utilize the ability of telepsychiatry, for example, as a way of promoting access, especially in the behavioral health community. We're looking at expanding the covered provider types, looking to expand covered locations, so where the provider can deliver telehealth from, where the patient can deliver telehealth from. There's a specific regulatory reform proposal churning its way through from OMH and OASIS, one of which is to maybe align the terminology between telemental, telepractice, and telehealth. So it's called one thing, and we're using the same term to refer to a larger umbrella of telehealth. We are looking at ways to promote and ease consent, whether through a universal consent process, which has the benefits of shiny connectivity, but also allowing for EMR interoperability, which is a foundation of being able to access medical records and deliver telehealth effectively. Thinking through ways to increase access points in the community, especially for patients who do not have a secure wireless or internet connection or privacy within the place that they live. And so to go to a secure access point, a community hub, if you will, to be able to access telehealth effectively and in real time would be one way to promote access. Looking at broadband access and connectivity generally, although that's a whole different panel, a whole different committee of Reimagine NY. And looking at ways that insurers specifically identify providers in their network that have a telehealth capability. And so, like you would go to your online provider directory now and say, who takes my insurance, and how do they serve, or do they have availability? You can see whether they have availability to have an online appointment more quickly than you might be able to get an in-person appointment. And some booking platforms like ZocDoc and others have built on that we can do that through the insurance provider directory construct as well. And then the last piece is just making sure that insurers are platform agnostic, so that providers who choose a platform, whether it's a Doxy or even a secure Zoom type platform, are not forced on buying multiple licenses to multiple systems, that as long as they have a HIPAA compliant and secure platform, they can use that to deliver telehealth with any insurance company. So there's a lot being discussed. Some of what I mentioned today is, I would say that's about, a sliver of the policy proposals being addressed, and that may make its way into a comprehensive government reform proposal in early 2021. But I wanted to make sure I use this opportunity in this keynote to let people know that we are using this opportunity wisely. We are thinking critically, and we are working to focus our efforts on addressing typical health equity disparities and promoting access to communities that have lacked access to the services pre-pandemic. And so I think there's a lot of promise here. And what I'll close on is saying, how can you help? Share ideas. We love ideas, especially innovative ones or even crazy ones. These are ideas that can help either inform aspects of policy proposals or new proposals themselves. So that's one way, either directly or through your associations. And the second way is last week, if you haven't seen it through the MRT listserv, we sent out a provider survey. I'll send George and Mark the link so they can share with you. But if you haven't already, please complete our provider survey on telehealth. It asks a lot of important questions and will help inform some of the decision-making process before we go forward. So that's what I got. I'm happy to open up for the next couple minutes for some questions, Mark and George.
Hi everyone, it's George. Thanks, Brett. That was really very informative. We're seeing if anyone has any questions, please post them to the chat. I just want to first start by saying I am incredibly grateful that you, with your history and experience and background, are in the room where where things are happening, and that's really critical, because I think you understand and can represent some of the challenges that I think some of the community-based behavioral health providers that are gathered here today have faced. And our telehealth, telemental health position paper really articulated a lot of the areas that you just covered. So I did have a question that I wanted to see if you could sort of shed some light on the issue around privacy and data sharing and consent. Could you elaborate a little bit more on that? Because I think that's really critical on so many different levels.
Sure. And this was actually a proposal that was advanced through MRT2 and one that we're building on with New York eHealth Collaborative and others. But right now, to utilize qualified entities or QEs through the Shiny, we have a very restrictive consent environment. It's an opt-in consent, and it's not community-wide. As many of you probably experience in your day-to-day, right? You have to, if you consent here, you have to consent there. Your health home consent doesn't work for your clinic consent, doesn't work for your telehealth consent. And, so people get consented often. We can't access the data by virtue of a consent provided on a very similar issue to another provider. It's not an opt-out, it's an opt-in consent environment. And that really limits our ability to utilize the statewide health information network to take the information that lives in that cloud environment and pull it down across providers so that they're fully informed when delivering a telehealth encounter. So we are thinking about moving to a more universal or community-wide consent requirement or an opt-out. Those are the options being debated, which is a community-wide consent says you can consent once for your community of providers versus an opt-out consent, which says that you are consented unless you affirmatively opt out, as opposed to the opt-in, which says you are out unless you opt in. And so, looking to be less restrictive on the consent environment so that the data can be exchanged interoperably among the EMRs, and that can be pulled down by providers that are, encountering a telehealth patient either for the first time or in connection with a larger care relationship. So that's what we're thinking on the consent issues. There are federal limitations that we're going to have to work through. For substance use disorder, 42 CFR Part 2 is a bear. And while there have been some pandemic-related flexibilities, we don't expect a federal regulatory change in that regard. And so we're always going to have to live with the restrictiveness of 42 CFR Part 2, which does require more specific consent for SUD. So we can try and go broader, but not go, on community-wide consent or opt-out. But I think we're always going to have a bit of a challenge with a lot of behavioral health data.
Yeah, thanks. I mean, it is a serious, we actually figured out that some of our clients sometimes need to sign up to 7 different consents to be able to just participate in the array of services that they're receiving. And that's, difficult to track and keep updated and, quite burdensome for the, providers. So I had another question. You brought up the issue of training providers, which I think is really critical. But the one thing that we call out in our Telemental Health position paper is sort of the digital divide, sort of this literacy, technology literacy that sometimes many of our clients don't have. And we sort of throw out there, and try to see if we can get some traction around thinking about how to staff, help clients gain competency around using technology, especially when they're doing virtual care. And I'm just wondering if there's any way of taking that into account as we're thinking about transforming, the whole telehealth platform. Where does training or increasing competency around technology for consumers sit?
Yeah, so I think the immediate proposal around consumer competency is working at looking at community health worker and facilitator models. So in-home community health worker type training that could give folks the comfort around utilizing, whether it's iPad based or other phone based or computer based telehealth technology, especially for things like remote patient monitoring and other asynchronous telehealth, which often has gear associated with it, or involve sending pictures, and those tend to be harder than initiating like a Skype or a Zoom call, which, through other aspects of this pandemic, people have actually gotten a lot more comfortable with. But that the question of consumer and cultural familiarity with telehealth is going to be, I think, partially solved fluidly through this pandemic. But then thinking about ways to repurpose, community health workers, which were a core aspect of DISRIP, and that a lot of PPSs had tried to do already. And had good experience with through CBO relationships. That's our thinking there, which is, can we actually, especially for the frail and elderly population, which has tremendous promise around telehealth for things like remote care management, that could be, that's our current thinking now. Although I agree with you, the training programs have not been specifically geared of late to individual consumer education. And that's probably something we have to think more about. Yeah,
we do have a question from the audience. Bruce Trigg, he's our addiction specialist doing all of our Project Echo work. He says, revised federal regs for prescribing buprenorphine for treatment for opioid use disorders had a huge impact on the ability of people to receive treatment by phone or video technology. The future, this is not clear. It would be helpful if state governments could advocate with SAMHSA and DEA to keep these rules post-COVID. Is this being considered at DOH?
I would say it's certainly being considered at OASIS, and we support it within DOH. I think the federal limitations with SAMHSA and others derive primarily from the Lying Hate Act, which is the long-standing federal bill that has restricted telehealth generally for controlled substances. And it's a really good question, and there has been tremendous federal advocacy. When we submitted comments on the draft interim final rule that CMS published in October, we did make these comments to support. It was sent out by Chris Tavella at OMH, but it was a collective response for all of our agencies, and we did make the specific call to relax flexibilities, especially what the government could do on a regulatory basis rather than a statutory one, because of the impact that Bruce mentions. And so it is on our radar, and it is advocacy. I think we were hoping that, I think we are hoping with the change of administration, there's going to be a thought for more long-term flexibility in this regard.
Yeah, thanks. The one last thing, you did mention, really making sure that telehealth is, delivered in a particular way and that we're achieving the right outcomes, and irrespective of sort of, return on investment and cost issues, which I think are important. Is the state going to take on any active role in thinking about how do we evaluate this intervention or this new intervention in terms of, especially in behavioral health? I mean, I know that, you're thinking more broadly around just telehealth in general, but in telemental health, like, is there any thinking around, whether it's through the state or through academia, to really evaluate the effectiveness of this intervention when it comes to outcomes?
There is, and there's been work going on with the Office of Quality and Patient Safety in DOH, which does most of our data analysis and studying, to look at the quality measures specific to telehealth, to see if we can measure long-term efficacy. So in addition to just the data analysis, data research aspect of it, the discussions we've been having within OHIP has been, is there a way here under VBP arrangements to increase flexibility long-term where we may not want to do it in a fee-for-service environment or in a straight managed care environment. So where you can do more telephonic in VBP than you could, sort of outside VBP, because of the long-term uncertainty as to whether it's simply driving utilization or driving utilization with a value. And that way providers are given the incentive consistent with their risk-based environment to study and present to us the information on, hey, we have chosen telephonic because in choosing telephonic, we're able to keep these patients in treatment. We're able to renew their medication and the adherence is better, and that's lowering costs through reduced inpatient psychiatric hospitalizations. And so we're getting better at our data usage on that and our test cases, but I would say we haven't put together a comprehensive research project, and I think we're relying on the provider community and the plan community to tell us, where things are again, merely driving utilization or whether they're driving utilization in a way that's delivering long-term value. The jury is still out on that, but it's a question we're asking.
Great. So Brett, thank you so much for taking time out of your incredibly busy schedule to really help us think through and better understand sort of what the state's doing on telehealth, telemental health specifically for the purposes of, our provider group. But like I said, I'm really happy that you're, as Hamilton, in the room where it happens. So thank you for joining us. If you need to drop off, I totally get it, but we are going to sort of pivot and jump into our panel discussion, but thank you.
Yeah, thank you, everyone. Okay, and please reach out with any questions. We're certainly happy to keep engaging on these issues, which are critically important. So thank you. Take care.
Thanks. All right, so we're going to pivot now to our panel. I'm going to introduce them in a second. There's a couple of things I just wanted to highlight. All of a lot of what you heard Brett talk about now sort of are things that CBC in collaboration with our programs and our health home CMAs and our IPA network providers put together in terms of our recommendations for some of the issues related to COVID and the transition to telehealth. That's why this panel is so important. Is there really a silver lining to all of COVID in terms of telehealth? But we brought up the issue of health equity as super important in terms of really looking at technology and broadband and access to it in our population, especially those heavily impacted by COVID, brown and Black communities. I think that's really important. We keep on saying telehealth is not, or telemental health is not the panacea. It's not going to solve everything. It should be considered one more tool or one more intervention in the armamentarium that we have as clinicians in dealing with the clients out there that might need telehealth. And when things go back to some level of normalcy, can we all figure out how do we adjust so that telemental health might be just one more option available to be able to engage with our clients. But again, I think we do need to evaluate and determine what the level of effectiveness is of telemental health in our populations, in the different diagnoses. What's the right dosage, frequency? I mean, there's all these things that I think we really need to figure out. So more on that. But what we saw was satisfaction both among providers and clients. We did see increased access in terms of just the number of visits, especially in those that are hard to reach and hard to engage. And we did hear from our providers that there was a significant, decrease in their no-show rates, which is all, good. So this telehealth transformation is happening, and I'm glad that we're able to at least, promote some of the recommendations. So I think. I thought Alex was going to, there it is. So in the chat is a link to our telehealth telemental health position paper, we advocate for, very simple things. We want, permanent regulatory relief on some of the issues that have happened, or some of the, the waivers that have occurred both at the federal and the state level. We advocate for those in the paper. We want some continuation of some of the administrative flexibilities. We really are a big proponent of enhancing, workforce capacity, and this issue around, out-of-state providers being able to provide services is fundamental. And then we want, we definitely are advocating for equitable rates and payment. Just a couple of other quick things before we segue to the panel and do the introduction. We talked, Brett mentioned provider training. Our, CBC, along with OMH, OASAS, and another IPA in the Hudson Valley region, CBHS, received the SAMHSA COVID emergency grant. We will be launching come January a series of training specifically geared to the workforce around COVID related matters. And we're really excited about launching this. There'll be, more information about that, coming out shortly, but it's really exciting. And lastly, just for folks to take advantage of the fact that, through our joint venture, CBC and CBHS, we have been offering discounted Zoom licenses. So for agencies that are still interested in looking for Zoom licenses, we are offering a significant discounted rate for those of you doing it through the joint venture IMSNY. So keep that in mind. So I am really excited about moderating this panel. I really think it'll help us scratch our head and think, is there really a silver lining to all this when it comes to telehealth? And hopefully at the end of this, we'll be able to answer that question, one way or another. But I did want to introduce our panelists, and I'm super excited that they all, agreed to join us. So we have Manish Vijayaravagan from VNS. She's the director of their community mental health services. I hope I didn't butcher your last name too much, and I apologize if I did. We have Donna Taylor. She's the clinical director for personal wellness plan HARPS at Health First. Been a big supporter of the work that that we all do here at CBC. And lastly, we have Edward O'Dowd. He's a peer specialist working in the community access pathway home. So thank you. Welcome to the panel. I'm going to see if folks have questions. Please put them into the chat box, and I'll try to manage them as we go along. But so COVID-19 has really disrupted how healthcare is delivered, and has challenged agencies and providers and payers to find new ways to engage with their clients. They've been widespread, these changes. The disruptions have been both on a personal level, on a professional level, on a sort of national, global level. And it's really sort of impacted how we conduct business. So I was just wondering if each one of you could try to encapsulate in one word, what has the impact of COVID been for you in terms of service delivery? If you could sort of, wrap your head around, one word that could describe sort of what this has been like for you. Manisha, can we start with you?
I would say challenging. I think it's one word, but I think there was so much anxiety in the beginning, and how to actually wrap our heads around everything. And then I think the other word is resilient. We've come out resilient on the other end of it, really thinking about being creative in the work we do.
Great. Those are great ways of describing it. Donna, can you come up with one word?
One word, I would say innovation.
Cool. There's been a lot of that. I mean, people have definitely had to figure things out on the fly. So yes, that's a good one. Edward, what about you? How would you describe, in one word, the impact?
Convenience. I have a very positive view on this.
Excellent. Can you elaborate a little bit more on that thought?
Sure. I mean, my first experience with telehealth was almost 10 years ago. As a touring musician and having a therapist in New York, I didn't really have any options for therapy on the road. And my therapist was gracious enough to introduce me to Skype and work with me on delivering telehealth services while I was on the road. And so the pandemic has been really kind of like back to familiarity for me personally, because I'm a recipient of services and I get them all by telehealth now. And it's had a great impact on my life personally. I think the challenge though is sort of the different demographics that we deal with. not everybody having access to computers, internet, and all that kind of stuff. Though, to me, those are the challenges. But at the end of the line, it could be convenience.
So that's a good word. Thank you for that. So given that everything happened so fast paced, right? I mean, you saw those graphs, the bar graphs that Brett showed, in terms of almost nothing in February, and then this huge spike, in March and April, and we have some of that data that we collected in our Telemental Health position paper as well, where we really saw this significant increase in these services. So can you, I'm going to ask each one of you specifically, can you tell us how your agency or you yourself or your plan, really adjusted and pivoted to, this change? Sort of what did that require? Donna, can you start telling us a little bit, what did Health First do and how did you guys, pivot?
So, health plans are really expected to adjust to new regulations and requirements. It's part of what we do in our business. And we have the experience in the infrastructure that enables us to make those big changes quickly. We also have protocols in place that prepare us in the event of emergency, like Hurricane Sandy or the pandemic. We are prepared to keep things going and provide continuous, support to members and providers. So, for example, at Health First, we've got very deep experience with telephonic case management. We were able to leverage that experience to very quickly move our on-site teams to remote workers and change staffing models that allowed us to keep, critical positions on site safely. Those changes were made really in just a matter of days. And because of that, we could effectively continue to push out information about the evolving crisis, information about COVID, information about telehealth that came in very rapidly, and billing guidance. I think I'll also share that from our perspective, sitting in managed care, what we saw very quickly was that our behavioral health providers really led the charge as early adopters of telehealth. And, at some point very early on in the pandemic, we noticed that more than half of the claims that were coming into Health First were for behavioral health services. That's really remarkable. On any given day in normal circumstances, behavioral health claims make up less than 4% of what we're paying. So, behavioral health providers really stepped up and stepped out to help communities in crisis.
Thank you. So that's a great segue. So Manisha, how did VNS adjust and adapt and pivot to telehealth?
Sure. So let me just talk a little bit about VNS and why, so everybody on the call knows who we are. We have been in existence for about 126 years and have about 44,000 members on any given day. But the community mental health division that I'm a part of, we provide a range of services, including psychiatric assessment, treatment, crisis intervention, and care management across all populations, children, adults, geriatric populations. And we typically serve the underserved populations, Medicaid and uninsured. And so we were fortunate that most of our programs, because they're community-based, the staff have tablets and cell phones. We had that already because we're already out in the community. We did have some few field-based programs that had more challenges. And given the agency, we were able to quickly turn around and actually get devices and access to stuff. Because I remember it was March 17th and everybody was working from home. It was kind of like a one-day thing and we, 2 days to get everybody what they needed. So at least we had that. I think the challenges we had were training staff, making sure we had the right apps to kind of use, thinking about just internal team meetings. We had Microsoft Teams. How do we get meetings together? We never used it before that time because all our meetings were face-to-face. So the biggest challenge really was helping our staff adjust to working from home, using the technology that they had. There were a lot of issues about working full-time from home. Families, did they have internet access? We talk about our clients and we'll talk about access issues, but we really struggled with staffing issues and making sure they had the resources to pivot to this new model of care. We have 5 ACT teams and we have an IMT team and we have several mobile crisis teams. So there was this issue. We are our teams do face-to-face work. That's our mission and that's our work. So there was a huge challenge for staff. How do we effectively engage our members? Are we doing the right thing? What do we do? So between thinking about their own work environment, thinking about the clinical care was really high on our priority. And one thing we did as a division was to create a clinical committee that really would drive decision making across our 30 plus programs, because we didn't want people to be thinking, is it ACT, is it this? How do we really think about what are we doing? How do we disseminate the information? What are the new guidelines? How do we feel that we are doing good clinical work regardless of the circumstances? So this clinical committee was really, really critical in our thinking. The first document that they came out with was to visit or not to visit, principles to decide and make decisions in the age of COVID. And really, again, just allowing space for conversations, for questions to come up, not to feel like we're in a vacuum, and really help 30 different programs, children's, geriatrics, crisis service, treatment services. We went from doing 9,000 to 10,000 visits a month in the community to only about 100 visits during the first, face-to-face visits. We didn't stop doing visits, but we had to kind of pick and choose and see what the needs were. We were administrating medication. So I think that really was critical. Obviously, we had a lot of training. We had to offer a lot of training. I think we approached it from, we have to train staff virtually. How do we do that? And so a lot of the meetings were virtual, supervision was virtual, team meetings was virtual. And to the point of training, we take that seriously, and thinking about training our clients and advocating for them, we have to be experts in that so we can actually share that knowledge. In terms of resources, as the pandemic has progressed, VNS-NY has made significant investments in technology. So in the summer, we invested in Zoom as an agency. We have rolled it out to all our clinicians. Everybody has access. Now the step is, engaging our clients in that and making sure that they have access and know how to use it. So that was kind of our transition piece in the summer. And recently, I think in November, the agency upgraded all devices. So we're really looking at making sure we have the tools to be able to provide good telehealth opportunities to our clients. I think that's the approach we've taken. We're still struggling. I think one area that we are still trying to figure out a solution is how to get electronic signatures from our clients. We have mandates, it's verbal consents are great. We'll talk about the flexibility that the OMH regulations have really, really helped our programs. But we have to think through, if we really want to do this in an effective way, how do we make sure our clients have access and are able to do things in a very streamlined way? We have DocuSign, but our clients don't have tablets or don't have PDFs and don't know how to use it. So we're still making the face-to-face visits to get consents, with mandates coming out. So there's still challenges. My wish list is maybe there's Zoom and we can sign through it. And so we're really thinking about technology and ways of how to make this really an effective tool in our toolbox. I know it's been a really rough year for all our clients and staff on many levels. So I just wanted to share one story of how, one of our programs, and we have many, but how we really accomplished so much, even being virtual. So our children and family support team, it's usually only a 12-week intervention program to work with families. And we received a referral in April, in the middle of the pandemic, for a 10-year-old girl who was who was witnessing domestic violence in the home. And we were helping the mom and the child. All this was done via phone and Zoom when, that the family could actually access it. We were able to actually help the mom make a plan to leave the home and move to Georgia. And she was very anxious. She thought it was going to fail. She was experiencing violence. And our team and our social work assistant likely had to call the family, the child and the mom every day and sometimes on weekends. When the family actually went to Georgia, they realized that that environment was not a good environment. It was actually as toxic. And they had to actually find a domestic violence shelter and placement in Georgia, which is not, was beyond our scope. And we were able to actually do that. And the mom and daughter were able to actually find a home within that 12-week intervention period. I think it's remarkable. And what it highlighted for me is we do this work every day. I think telehealth telehealth, telemental health, the ability to capture this in a different way highlights all this work we do with collaterals that actually binds the work we do with clients. Face-to-face visits are important and are great, but telehealth and this environment really solidified the importance of the type of work we do. And telephone calls, Zoom calls, virtual calls, all of that help.
Yeah, thanks, Misha. That was yeah, super interesting, and what a great story. So I'm going to pivot to Edward, and maybe you could tell us a little bit about sort of what this transition to going from predominantly face to face to virtual meant for you and the work that you do.
Well, it's definitely been a challenge to deliver services when you can't see someone. And I'd say it's probably, for me personally, it's about a 50-50 mix of those who have the ability and access to the technology to engage, and 50% who don't. Those that don't, I'm still seeing in the community, but socially distanced with PPE and all that. But it definitely brings, a great challenge. Getting people comfortable with the technology is definitely seems to be the most complicated aspect.
So let me just sort of follow up on that, Edward. So in terms of your pivoting to telehealth and obviously trying to engage folks into sort of that modality. What's your sense of personally for you as a clinician or as a provider of services and your clients? Like, are you seeing resistance or barriers on their end? Is it coming maybe from you? Like, sort of help us think through what it was like for you in terms of the work that you do with your clients in terms of using virtual care like that.
Oh, sure. I mean, the barrier definitely not on my end at all. I mean, I had to sort of just, jump headlong into it. But I mean, I tried to offer creative engagements as like broad as I possibly can, to generate interest in people joining. I've run groups on Zoom. Those have been generally successful, but the resistance is sort of, well, I don't have the technology, or I don't know how to use it, or I don't have a place where I can Zoom comfortably, right? If they're on the street a lot, if they're in the community a lot, pursuant to, what was said before by Brett about these, potentially having telehealth call centers. That's a very strong idea, because that's one way where people could go in individually, things can be wiped down, and they have their half hour or hour to engage. I think we do need some assistance in that department in terms of, more resources to leading people to this technology.
I remember when we were doing, when we were interviewing providers and clients that were using Telemental Health for the position paper, we did encounter a lot of feedback from folks saying that, their home settings weren't as conducive. And obviously, if you're either precariously housed or homeless, that's even more of a challenge. But, folks that did have, they were confronted with all of a sudden, they've got they're at home, their kids are at home, they're trying to get school, and to do an sort of a remote session was incredibly challenging from a privacy perspective, from a comfort perspective. Yeah. People didn't want their backgrounds to be seen. So I think definitely that was something that we heard loud and clear was a challenge. And I think what Brett mentioned about these, I'm thinking about like the internet cafes at the beginning where we'd all go to a cafe to log on. I mean, maybe. Yep. There is something to be said about creating some community hubs that might be, safer spaces for folks to access, those remote services.
Right.
Manisha, in your agency with your providers, did you encounter any reservations or concerns? Because we've heard a lot of folks saying, well, telehealth, it's not the same, and you can't establish that, that therapeutic rapport. And so, what did you guys encounter in terms of your staff?
Yes, I think we had challenges on both ends, staffing, and I think, part of it is staff are used to telephone calls. We do this all the time. I think the pivot to doing the video conferencing, using technology, the face-to-face visits, people had challenges. They wanted to meet people. I think our crisis teams were very challenged, and we actually had rounds and meetings to say, Are we accomplishing what we are doing? Are we able to do this assessment? We're doing it on video. How are we feeling? Because that need to kind of go in person is very strong for our clinicians in terms of the type of work we do. So, you know, we had both the staff that were kind of very challenged by their own work environment and their own privacy issues, not knowing the technology and the clinical work and understanding how they can pick up cues. There were staff who just wanted to go out there and said, but we're not, you know, this is our job. We have to meet them face to face. In terms of clients, Ed's, you know, what Ed said work is actually true to us too. We actually did a survey and I'll share some of that information later on. But what we found was our clients were very appreciative that they were connected to us. Now, most of the work was telephonic at the time. This was early in June and July when we conducted the survey. And 1/3, though, of them did not have the capacity to do more than telephonic communication. And so, you know, the devices they had, phone, they only a home phone, only a work phone. So there's a huge access issue, and I don't think we've addressed it. We're trying to work with the people that have it to kind of educate them on how to use it. And it's not necessarily only to work with us, but we think it's a really huge benefit because they can see a PCP and other providers through this method. So I think, you know, one of the things we're thinking through as we come out of this pandemic, how regardless what program it is, field-based, office-based, how do we incorporate this as part of our enrollment and education process? Do they have technology? Do they have devices? What can they do? Again, may not be for us. We might see them face to face, but giving them access to other options for their care, I think is critical. And that's a piece of education, accessibility, and kind of inquiring about that we don't tend to do, right? We take it for granted until it happens. And it's something that's extremely important. We were lucky. In some programs and most programs, we have wraparound funds. So we were able to ship and order devices and buy plans. We do have some programs that did not have that, but we were trying to think of creative ways to apply for grants. And there's going to be definitely a lot more advocacy on that. We still have challenges. We have a Shelter Act team and it's very hard. And we're trying to advocate, how do we get a space and devices available for those clients so we can have the communication, and it's not easy. And then of course there are clients. We do have clients we bought devices for and who have not used it or don't want to. So there's going to be a lot of education, a lot of practice to kind of engage members and see what really works for them. I think our first responsibility is education and advocacy to get them what they need, and then, you know, pass out what really works and how we can make it happen.
Yeah, thank you. Donna, so in light of everything that sort of occurred, you did mention that, you know, more than 50% of the claims for coming in were from behavioral health, and you guys had to, again, adjust, you know, having spent some time in managed care, I know how difficult, you know, it is to be able to, you know, pivot as quickly and responsively as I think, you know, many plans have done. But I'm just sort of going, so there's a couple of questions or a couple of concepts within the question is,
Sure.
you know, the transition to telehealth and all the changes that go along with, you know, the billing and the claims and the guidance, you know, sort of how did telehealth, you know, how did, you know, Health First manage that and then convey that information? But then, you know, going back to Manisha's point and, you know, even Edward's point about sort of, you know, access to the technologies, like what role did Health First have, or should they have, or if not, you know, let me know. But like, you know, in terms of being able to facilitate some of that transition as well as a plan for your members.
Well, so again, you know, plans do have systems in place to adjust to changing regulation and new billing logic. I think what was, you know, particularly challenging in the early weeks of the pandemic was that, you know, things moved very quickly and telehealth was green lighted before any of us really understood how we were going to bill and pay for it. And, you know, we were really okay with that. I think everybody was okay with that. It was the right thing to do. You know, where we all eventually landed was that the services would pay with a modifier. And it did take a while for everybody on the inside and the outside to get together and get on the same page as to what those modifiers would be and, you know, how this would all work. I think overall, you know, from my perspective, the whole process went fairly smoothly, not perfectly. We did at our plan have some early denials of telehealth claims that had come in very quickly. And fortunately, we were able to manually reprocess them and get them turned around and fix those glitches that were causing hiccups due to coding errors. In terms of helping our clients acclimate to telehealth, again, a lot of our highest risk, most vulnerable clients have had some contact previously with telephonic case management. So they were a little bit more accustomed to at least sharing information telephonically. And quite frankly, the feedback that we've gotten, generally speaking, about the telehealth experience has been mixed. We've heard from members who love it. We've heard from members who really miss in-person interaction and are looking to quickly get back to an office space. What's not mentioned here is, it hasn't been mentioned, is the feedback that we've gotten from many families about how difficult it's been to engage school-age children and adolescents. And the adolescent population in particular was a surprise for many people because they're on the computer all the time and they're gaming. Contrary to, I think, popular belief and assumptions, our older adults really adjusted very quickly and loved the flexibility and ease of access that telehealth provides. That said, they really complained a lot and let us know that generally, as a system, we did a really bad job onboarding them and getting them acclimated to telehealth platforms. And as Brett had mentioned earlier, there's a lot of work to be done and to figure out in terms of how to better get people prepared for, all sorts of platforms. I think, it's fair to say that overall our experience is that telehealth, continues to provide an effective way for us to link individuals, with mobility and transportation issues and other barriers to the care they need. And, in this way, it seems to really have leveled the playing field. It is providing for, a particular group of people a way to access care that they wouldn't have had previously. And, on the flip side, as, everyone has, already mentioned, we do understand that there are individuals who can't access and can't utilize telehealth services because they don't have a phone, they don't have a screen, they don't have internet services. And, so in that way, in that manner, access isn't even. I don't think the answer is to stop offering telehealth services. Our job is really to continue, I think, to work together and find new and different ways to utilize all that's available to us to help individuals get the care that they need when they need it. And going back to something you said, George, earlier, telehealth is not the be all and end all, but it is one important arrow in our quiver, and for those, for whom it works, it's really great.
Has Health, just as a follow-up, Donna, has Health First done any sort of, sort of looking at data in terms of outcomes? I know it's kind of hard because, when we're thinking about outcomes, you're thinking about impact on hospitalizations or ED visits, and all of that was sort of, put on pause. Especially we saw that a lot with our, behavioral health clients. But like, just wondering, like, was there any effort or is there any thought about maybe looking at some of the claims data to see, has there been any, positive impact, again, in our population, right? HARP, let's say, those with, SMI, SUD, some of the kids with, serious emotional disturbances. Has there been a look at the data to see if there has been any sort of, any outcome, or any up or down, in terms of
Right. It's really, for us, it's really much too early to dig into the data in any meaningful way. What I will say in terms of any impacts is that our providers, all levels, are consistently reporting that a very early impact is that their no-show rates have decreased dramatically by almost 50%. And, if that's a trend that continues to hold, I think that that's very good news. But beyond that, in terms of efficacy, the verdict is still out. We need a little bit more time and experience to make that call.
Manisha, what about you guys? Have you had any ability to think, even if it's not sort of doing deep data analysis, but like, think in terms of, your client population, especially those that are hard to reach, hard to engage, and, the last 9 months of, mental health interventions?
Right. I agree with Donna. I mean, the no-show rate has definitely decreased. We have an Article 31 children's clinic, and, we'll speak to that. Actually, the members we have been very engaged, and we did a survey across all programs, but looking specifically at that population, about 60 to 70% wanted to continue telehealth because it helped them get to appointments, transportation, and having, the children after school. Most of the appointments are after school, and it really gave them something to, be able to keep the appointments. I will say that referrals have dropped. So there are no new referrals. And so that's a concern. We know there's a need. And I think that speaks to what Brett was talking about, making more education about programs that exist and how to make them. I think for the children, it's been really hard because schools was our primary referral source. And so with the crisis teams, we have crisis teams for children and adults. Adults have been relatively stable in terms of referrals. Children's have dropped. And we do know that there's a huge need out there. In terms of outcomes, I do know the clients who have been connected are really connected. We do worry about some of the clients who have been hard to engage, and we've tried to go out, and we worry about them a lot. Not a lot, a small sliver of our population. We do have ACT teams. I think, the sudden dip when we looked at some of the data in the summer, I think was because people started going out more face-to-face. We did, definitely. All our programs, our Pathway Home team, our ACT teams started to go out more, and we're doing more now, even though, we're trying to curb back for safety reasons and make good choices. And clients wanted that. And so where do we find the balance between that? If you would like me to share, I'll share a little bit of the survey results that we did sometime in June, July. We surveyed, and this was part of our effort to say, are we doing a good job? Quality is important. Is this working for people? What are their needs? So we had about 15 questions we asked, and we really wanted to target telehealth, right? And so about 1,200 clients actually responded to the survey across all programs, geriatrics, children's, ACT, and care management. So we were able to kind of also break it down a little bit based on programs. We asked questions about the experience with telehealth. And like I said, overwhelmingly, the clients who responded were really appreciative. Now, there were clients who did not respond or we had not, been in contact with. They reported telehealth was very easy to use. I think something similar to what you found when you surveyed your providers. I will add that at the time, most of the contact was likely via phone. Like I said, we found that 1/3 of the population actually didn't have access to video conferencing. The program that had the most video-based visits at the time of the survey, that's about 60% of visits, was the clinic, the children's clinic. So they were really engaged in using that opportunity really quickly. I don't know if it's because, they had the equipment because of the schooling and they were able to get on much more quickly in terms of education. The issue, I think we asked our members, what do they prefer? Do they prefer telehealth visits? Do they prefer only face-to-face visits, or do they want a mixture of both? Again, this is early on. I think we will have to, retake a survey. And the answers vary based on program. For example, we have a wellness care management program that's a contract to HRA, Human Resource Administration. So it's a field-based operation. Where clients or members have to come in, mandated appointments to get their work done. 80% of that population thought telehealth worked. These are mandated appointments, and if they could have telehealth, that's all that was needed to kind of work it out. And the other programs, generally speaking, I think 80% of across the board of all our other programs that are more community-based wanted a mix of both face-to-face and telehealth. While they thought telehealth was great, and they 80% wanted telehealth to continue in some form after the COVID emergency. That is another question we asked. So, I think this was our initial kind of way to communicate and get feedback and look across programs, because we do know there are some programs like our ACT programs and Pathway Home that need more frequent visits. The initial engagement, and we believe that across all programs, initial engagement, enrollment, should happen in some form or fashion in person. And so how do we balance that? How do we decide what one person needs? Of course, it's a person's choice, what's working for the person, and what combination. So I think this outcome and research study that we had talked about would be great and really help us, determine that. To your point, I believe that this is a tool in our toolbox, and it's not one way or, face-to-face or just telephonic or just video. It's what works for the member, what's really keeping them healthy in the community. And it can change, it can pivot to something different, and how we as a behavioral health community can actually identify that and meet those needs is something I think that, is the future.
Yeah, oh, absolutely. Thank you. Edward, your you've gone from working, in the field with clients, especially, on the Pathway Home program, which is, very much about really hard to engage and hard to establish these relationships with some of these clients. What's been, what have you had to do differently using telehealth in terms of strategies for engaging folks? Because I'm assuming, the face-to-face, you got a whole bunch of cues and things that you can do with a client when they're in front of you versus on a call or even, video. Can you tell us a little bit about how you had to modify some of your strategies for engaging folks and what that looks like?
It's been about innovation, really. It's sort of, coming up with engagements that participants would like. So it's kind of, being able to offer a wide variety of engagements that sort of brings people more comfortable and, okay, well, maybe I'd like to do that. If I'm offering a yoga class, like that's going to sort of guarantee a certain amount of people who come from our caseload that are interested in that, who will, turn up on Zoom. Computer lessons, resume writing, studying. I basically just sort of impart to, to participants that anything that they'd like to do is possible on Zoom. And so we sort of collaborate and come up with engagements together as well.
You mentioned innovative, like what's been the most sort of creative or innovative strategy that you've had to employ to engage someone?
I think giving computer lessons, been a bit of a challenge. Yeah, it's challenging, but it's, I'm fortunate also to have been a college professor. So, I've got that experience. So teaching is not really difficult for me, but yeah, I'd say that was definitely the most challenging was, computer instruction.
Right. And let's just say in the last, 9 months that you've been sort of, in the middle of this, what's been sort of your clients' response to all this? Like, so what have they conveyed to you in terms of, changing over from, more face-to-face to virtual?
Some simply just won't do. They won't do it. And that's true, the choice. I've had people say, well, I'd rather not be seen at all. But more often than not, it's like if I'm able to mix a combination of telehealth and seeing in person, that seems to work the best. Without that in-person engagement, it's very difficult to get somebody to come on screen. And so, that also leads to, instruction in the community, right? Of like wiping a phone down, with gloves and handing it, okay, so we learn how to use the technology in person, but we have to employ social distancing standards as well.
That's really interesting. So we're 9-10 months, and God knows how much longer this might continue, but we're about 9 months into the pandemic, and we've had all this transition, right? So just wondering, and I'm going to ask each one of you to see if you can answer it from your perspective. How do you think what we know today versus what we knew back in March? Like, what could we be doing, or what should we be doing differently with telemental health? Like how can the experience be improved? Like, what are some thoughts about that now that we have a lot more time under our belt in terms of having done this? Donna, can we start with you in terms of that question from your perspective? I know it's a hard question.
It is a hard question. I think, again, we're learning. One of the things that we do at the plan in engaging our providers is to see if we can identify best practices. And when we do, to share them and push them out. We draw on best practices in our own business, in telephonic care management in particular. I think understanding over time how to make the best match between telehealth services and populations, and doing a better job of engaging those harder to reach populations. Again, it's not a one-size-fits-all strategy. I was interested in some of the things, a lot of what Edward was saying in particular, but I will share that for me, I've been a professional. I've worked on Zoom and remotely for 10 years. As a person, I had a really difficult time with attending online support groups. And, there's a group that my husband and I have participated in for years, and we fell off, and that was a surprise. Again, why? I don't know. I guess I really crave that in-person connection. So again, I just think that there's a lot we still don't know. And we just need to be committed to working together and evolving it forward.
Well, that's good. It's a good point. Manisha, what about you in terms of, 9 months into this, sort of where and how do you think we can improve the delivery of services via, telemental health?
I think, I agree with Donna. I think we're still learning, and so collecting data and information and seeing how things have worked, in different times. But also advocacy and education, I think, is a big one for me. I think, we're learning. We switched, it was like switching something on in a day. Even though we had devices, we worked on it, we were not really prepared. And so we're learning as providers and as staff. And I think we have a lot more work to do with our communities and our clients. And I will say, it's not just about us doing the work. This is something to stay. They can have PCP appointments via telehealth. They can really access other services, and how we can do a better job of that. I know it's harder virtually, and our goal when we come back is really build that into the process. Regardless of the program, it's an access issue. It's a social determinant of health issue. And how do we track that and educate communities and bring resources, perhaps, like broadband access, which may eliminate some of these things, is something I think we can do a better job.
Yeah. Edward, any thoughts on what we can do to improve?
Education and access. It's all about that, as far as I'm concerned. Yeah.
Excellent. So as you were talking, Edward, about your experience, a panelist said, so around innovations, using a session to plan a virtual birthday party via Zoom is something that they had to do with their client. It was totally relevant to their clinical work, maintaining a positive support network during this time that was crucial to their clients. So again, I think, what I found fascinating is obviously, it resonates with all of the things that you guys are saying, and some of the work that we had in terms of uncovering data for the, for the position paper is, people are incredibly creative and innovative. And I think that and I like that someone mentioned innovation, as the defining, word is people have had to adjust. And, we didn't wait for, the city or the state or the feds to tell us what or how to do. We did what, we do best, which is when dealing with, another person in a therapeutic relationship, is do what is necessary to help them through the situation. And I think that, that's what's kind of cool about, the feedback that we're getting. I love the fact that, it was a virtual birthday party, and, you're doing, yoga lesson or whatever it may be, that really is about really engaging folks where they're at and what they need to do. There's a question from the panelist about, collaboration among, providers and collaterals being really important to the delivery of care. Has there been, has there been any, can anyone speak to their experience in managing sort of case conferencing or family sessions virtually, and what that looks like in terms of the impact on the individual's plan of care?
I can speak a little to it. It's been challenging. I think, first we're engaging members, but we have been successful in our parachute team. We do some family sessions. It's been a little bit more, again, it's about education, getting people on board and having an experience. I think the way to approach it is, let's try something and let's see how it's working. And it's also come back and say, process, how was that for you? And kind of move forward with that. Providers has been challenging, actually, I will say. And it's not, I don't think because people don't want to be helpful, but it's just, we've been all on this kind of roller coaster ride, and especially, clients coming out of the hospital and discharges and appointments, and we're not getting appointments within 30 days and 60 days and really managing the care till that happens. That's been a little bit, I know staff, we're working really hard. I know, even just for our own agency, we were getting snail mail and nobody's in the office to pick it up. So really thinking about pivoting and having emails and different ways to collaborate with other providers, not just a phone call where the voicemail is full. those are things I think we can do a better job. We definitely have tried to be responsive, and we're hoping we're getting the message out there of how we can be accessible in this kind of environment, which is really different from traditional ways. I do think there's many opportunities to do better collaboration between providers. I'm not sure how.
Yeah. Don, are you seeing in your claims data, I don't know if you have the answer to that, but are you seeing in your claims data any indication of like, this type of collaboration or family sessions? And I don't even know if that would be, billable services or not, but like, are you seeing any of that?
We're seeing all services being billed via telehealth. So we really haven't seen any provider group not take a step forward to take advantage of telehealth and to start experimenting with it. I think, and to pivot a little bit, one of the things that continues to be interesting to us and something that we'd really like to understand as a plan better is the whole notion of access, right? And what that means to different people. Clearly for individuals who can't make an in-person visit for any number of reasons, telehealth is improving access, and that it provides the opportunity to get services if a provider is available. Now, whether or not provider availability has improved, isn't really clear. And I hear very mixed messages from our care managers and my colleagues and providers about that, particular issue. So, I don't know if anybody would like to weigh in and maybe share some of their thoughts about that.
Alex, can we, do folks, I don't know if Manisha or Edward want to sort of, chime in, but maybe folks on the call as well. We've got, a whole bunch of providers on the line.
Chatting.
I can speak to, I know we are willing, we've pivoted so that we want to take referrals. Like I said, we have a children's clinic, so it's a little different. And we have had the experience where we have been waiting for appointments, so it's much harder to get. And, we have pivoted to actually going to face-to-face appointments for mental health appointments. I think the bigger challenge has been the physical appointments, which are longer in nature to get. So I've also had mixed experience. I think we are responsive. I mean, for other programs, for our ACT teams and our health home, we're still getting referrals. And the flexibility of the OMH regulations have allowed us to take on that population and serve them, in a way that's meaningful. So I think there are definitely providers who are doing a great job. And, the telehealth does offer the opportunity to provide more services to more people. Just in the nature of, the community work that we do. We travel to somebody's house. There's so much travel time involved. There's so much more we can do while remote. I hope that answers your question, but I definitely think there are many more providers on the CVC side that, might have a difference and a different experience, perhaps.
So if folks want to address that via chat, certainly put your comment in, or we can, ultimately at the end sort of unmute folks to
Right.
chime in as necessary. But
and in all fairness, it might still be very early, much too early in the process to really look at the impact of that.
Right. But I think, sort of what Brett, mentioned and sort of what I alluded to at the beginning is, the ability really to evaluate this, like, is a, 15-minute telehealth session the same as a 30-minute in-person or 45,
Right.
like, I think we need to really be very clear about, what one of the things that we did here is that at some point, certain groups just peter off, like they just can't be on 45-minute. I mean, look, I have a hard time staying on a, on a meeting that's an hour long as well, because I get distracted and I'm like, I'm all over the place. But so certainly I think that's a challenge. I think we do need to look at that in terms of the effectiveness of the intervention and really looking at, what I talk about, a dosage or a frequency of the intervention. I think all those things are really critical for us to understand. And I think the jury's, still out on sort of where all that's going to land. But I think someone's got to take up that responsibility to really determine how impactful these interventions are and what the right, number of sessions or timeframes are. So I'm going to just sort of, ask each one of you to tell I keep on saying, the genie's out of the bottle here, right? Like, once telehealth, when you looked at that graph that Brett showed, from almost zero, 500 to 55,000. I'm not a mathematician. So I don't even know what percentage increase that is, but it's significant, right? So like, we it's out there, right? And it's going to be really hard to put this back in and say, no longer are we going to do this. So like, do you agree with that? Donna, do you agree that this is out there now and it's going to be hard to go back to pre-COVID?
Oh, absolutely. You know, we're all seeing signaling at the federal level and the state level that telehealth is here to stay. And, you know, that government is working on what this is going to look like post-COVID. And, you know, that's great. You know, Brett mentioned there's a lot of work to be done. And I think that that's understood. And, you know, we look forward to being part of those conversations.
Manisha, what about you?
I agree. I'm in agreement. I think, you know, to the point that Brett made earlier, it was really slow for behavioral health, at least OMH licensed, you know, to put in the applications of telehealth, and the regulatory kind of requirements potentially, you know, were challenging. This really forced the issue to try it out. And, you know, flexibility in the regulations helped us do that. And now we have to kind of take a look at the data and see, you know, what it is, but it is here to stay. And I was appreciative of his, you know, Brett's conversation about what's, you know, things they're thinking about. And I think they're really thoughtful. And I'm hopeful that we really see, you know, it is meaningful when we come to the other side, that the application, the kind of work we can do, the flexibility to meet everybody's needs. It's not just one way. I understand the issues about telephone calls, but sometimes that's all what's, you know, that's the only thing somebody has and it works. And so how do we kind of balance that is really going to be critical.
I agree.
Edward, your thoughts?
Yeah, I'd like to add in that I think it's also going to have a significant amount to do with the providers themselves. Because, for instance, you know, the two providers that I use for telehealth, one I know will not go back to in-person anytime soon because of their age, their disposition to other conditions and whatnot. And so that's here to, as far as in my world, that's going to be here to stay. And I think that's wonderful. I think that, you know, in terms of signatures and stuff like that, yes, that's going to be something that really has to get worked out. And this, of course, you know, this is my thinking. But I mean, you could even have somebody sign a piece of paper and you could take a screenshot of them. You know what I mean? It could be that simple.
Right.
It's just a matter of, you know, those in charge of making those decisions need to, you know, come up with those possibilities.
Yeah, and I think, you know, what's positive about this is that at least these conversations are being had. Like, we're having the conversation. We know that at the state level, they're having the idea of a universal consent. I have been, you know, knocking on that issue for years now. Right?
Yeah, absolutely.
Saying it, and now finally to hear, you know, someone from, you know, from DOH, you know, that they are talking about this is hugely impactful. Yeah. So I think all these issues about, you know, consents and signatures and how we're going to do this really is because of the pandemic and everything that's happened and how we're needing to pivot and transition. So. So I'm going to just ask, you know, the title of the panel was, you know, the silver, you know, is telehealth, you know, the silver lining of COVID-19. Do you guys think that in all of the craziness that was COVID-19, is this a silver lining?
Yes.
Edward, thumbs up.
Yes.
Okay.
I think it's shown how resilient we are as a community too. And, you know, we've been able to really pivot and use something and go with it. And it's really about making our communities healthier. I strongly believe the behavioral health community is really, I may be biased, but we are really mission driven, and, you know, it's about healthier communities. So yes.
Yeah, I guess I would add that, you know, while telehealth is clearly not for everybody, my hope for all of us is that we will, you know, leverage telehealth and embrace the fact that we're no longer tied to traditional bricks and mortar to evolve, you know, effective and efficient, longer lasting, sustainable hybrid models of care that, you know, help us fully take advantage of the tools and resources available, you know, to us across the state to bring people to care. So I think this is a wonderful opportunity.
Yeah, and I just want to chime in as well. I do think it is super positive, and I think just by virtue of the fact of having, you know, providers and plans and the state and associations all having these conversations in a sort of very, you know, open and transparent and collegial manner, I think is really critical. I mean, I do have to say, I think, you know, Health First has been, you know, sort of just steadfast in its partnership with many of the community-based providers. And I think that that's the type of, you know, leadership we need to have with all the different stakeholder groups around how do we excuse me, transition and pivot in a direction that's going to really improve accessing the services and improving outcomes across the board, which is, I think, what we all, are in this field for.
Yeah.
So I think my God, we're exactly at, time. We're going to open it up to Q&A. I see, so here's a question. With the usual referral sources like hospitals and schools not having contact with potential referrals, have any of you begun to think innovatively on how to market programs and educate potential service recipients on what is available and how to access care? So let's, Donna, like from the perspective of, your care managers, you're doing telephonic care management, like, have you guys been thinking about how do you, prime the pumps of referrals, in terms of, sort of moving forward?
Yes, and throughout the crisis, we have kept up-to-date lists of who's doing what and who's available for which groups of clients. I think, under normal circumstances, health plans generate maybe 6% of referrals to behavioral health care. We've certainly taken on a much larger chunk and have gotten out and gotten in front of hospitals and other community partners to really let them know what's available and how to access care, and really stepped up the work that we do to make those connections and make sure that they've stuck.
I actually can speak to that because we have a collaboration with Health First, working with people coming out of the hospital. And, it's been challenging. So we actually have been approaching inpatient units just about education, building that collaborative effort for that particular project.
Mm-hmm.
We have talked about, our children is one worry. We have tried to broaden. We do community Zoom meetings to kind of engage more people. It is a challenge. We do the schools and the way the remote work is working. It's a tough one. And we do know, we would think the referrals will come through our crisis services. So if there's any way we can partner with the state and DOHMH to make that more available so people are actually, making the calls, it is something we can do better at. I think definitely, unless you're in the field, how to make the referrals. There is so much there. And even us actually learning 311 and the food resources for our clients. It took us a while, what is out there? How do we get that in? How can the plans help? Who has the resources? And sharing that was really critical in making sure we get out to people and then get the referrals so we can do the work.
Edward, on Pathway, what's it been like in terms of, the marketing? I mean, obviously, we did see a decrease in, inpatient hospitalizations. Obviously, people transitioning from inpatient to Pathway is sort of the, the lifeblood of what we do, right, in Pathway. So what's that been like in terms of, new sources of referrals and what you guys are needing to do differently to get folks onto your team?
Well, I'm not sure because I'm not really involved in the referral process.
So you're seeing, but you've seen a steady flow of folks coming to you, though.
Yeah, we definitely. I believe that we